Bill Halsey, who's our Medicaid director, and to do a little intro.
Hi, everyone. Thanks, Brad. Commissioner Barton Reeves wanted to be here today, and she just wanted to make sure everyone realized that we sincerely appreciate everyone's interest and feedback and suggestions on this maternity bundle journey that we're about to embark on in January. We have tried as a department to incorporate that feedback as best we can into the model, almost up until the last minute. And so we continue to appreciate your commitment in serving Medicaid members, and even post-implementation, we look forward to your engagement on how to consistently and continually make this program better. So thank you again for your participation and your interest in serving the Medicaid members.
Thanks so much, Bill. So we can go to the next slide. So kind of things we'll review, goals for today. Going to review the program goals, overview and stakeholder engagement to date, review what practices expect on January 1st launch date, and answer any questions about the maternity bundle that are outstanding or that you still that you have. Next slide. So just a reminder of our goals and overview of the program. So we're excited. We're launching this on January 1st. It's coming up very soon. And we really appreciate all the engagement to date from all of you and all the others that are not initially on today, but we anticipate ongoing engagement after the launch. We know that this program will require ongoing tweaks and modifications to make the program work and be successful. And so just as a little bit of a reminder of our timeline, we really started this way back in 2020. And so we're excited to launch this in 2025. And we've done quite extensive stakeholder engagement with our advisory council. And we've held numerous provider forums and office hours this year, as well as had the chance to meet with many of you who are on in one-to-one meetings, which we're still happy to continue doing. So again, we will be continuing with engagement. We know it's really important for the success of the program, which ultimately means improving the health and well-being of our members and the newborns they're delivering. Next slide. So just of note under this program that we're calling it maternity bundle, includes a number of different components to it. And so you'll hear kind of maternity episode and bundle, and includes things that around cost and quality of care. And so we're, again, launching this January 1. Eligible providers, those who are included, are those who have delivered 30 or more births per year. And then the episode of care is kind of that time frame. So it's from conception to 90 days postpartum. So it's prenatal, labor and delivery, and postpartum periods. And so kind of the goals, I'll just remind folks of why we started doing this in the first place, is really to strengthen maternal health in Connecticut, promote health equity, improve health outcomes, increase patient satisfaction, and reduce unnecessary costs. Next slide. And so, one of the things that we've had to date, we've had our OBP4P platform, which was started a number of years ago, and probably a number of you participated in. But we've continued to see kind of outcomes and a rise in adverse outcomes that were concerning to us, as well as increasing C-section rates and NICU utilization rates with marked disparities across various populations. And so really with that in mind and seeing that, we really wanted to make a difference. Medicaid accounts for about 45% of all births in Connecticut, and our C-section rate is about 33%. That was in 2020. And that's the 7th highest in the entire United States. And again, we've see alarming rates of these adverse maternal outcomes and C-section rates that we think can be improved upon. And we know to do that, we really have to change how we're incentivizing care and allow providers more flexibility and provide more accountability for the care they're providing. Next slide. So this is a little overview of the episode-based payment model. So currently, we've been paying in this fee-for-service. There's a global code, which is billed kind of in a traditional CPT fee-for-service manner that provides payment for the volume of services, regardless of the quality or outcome. The OBP4P program tried to incentivize better outcomes around quality measures, which many of you are familiar with, but still it was mostly billed off of on a fee-for-service chassis. And so the maternity bundle really moves to provide more accountability for quality and cost to providers during this episode. And so you'll hear a few key terms: provider-specific case rates. These are monthly payments that are made starting the 2nd trimester. They can be made through the end of the 90-day postpartum period that encourages delivery, flexibility of care delivery, incentivizing early engagement with the members. Incentive payments, here's shared savings bonus payments. Those who meet specific quality standards and lower the cost of care can share in savings with the state. And that's to incentivize unnecessary cost and improve efficiency. And we also have new doula and lactation support services that are covered. And so that's, again, to enhance patient-centered care through high value and peer-based services. And then we have specific quality measures that we worked on with our advisory council, and we brought in Yale Core to help us with to ensure high quality care and improvement in care as a focus here. And then we're incorporating social and clinical risk adjustment to help account for members who have higher, greater social and healthcare needs, and account for that in how we're incentivizing providers. Next slide. So this is our state plan amendment approval. So we're actually really excited to announce that we have CMS approval to launch this through the state plan amendment process that was granted approval on November 20th, 2024, and has effective date of January 1st. So we have that has been completed. We started this process years ago and are really excited to have gotten over this finish line, which is a significant achievement for us. And so we're really excited about it. I know maybe for those who are less involved in the Medicaid policy, it may not be as meaningful, but this is an extremely important part of our process. Next slide. And so I'm going to pass it over here in just a second. Joined here by a few other, we have a lot of team members on who've been really involved and instrumental in getting us to where we are today. So including Tiffany Lunan from Faulkner Consulting Group, Grace Zhang from Mercer, will be speaking as well. So I'll pass it over.
Thanks, Brad. In this next section, we'll be reviewing what providers can expect once the program launches, coming soon in January 1st. So first off, the biggest update that providers can expect is once the program launches, practices will be able to initiate and start receiving case rate payments for their second trimester patients only. As a reminder, to qualify for case rate payments, providers must meet the following criteria to indicate a trigger event, which is how DSS will initiate and recognize those case rate payments. So the first criteria is going to be automatic for participating practices. That's going to be performing 30 or more deliveries per year. Next up, to initiate the case rate payment, providers should submit claims with trigger diagnosis codes as well as specific E&M codes. These codes are listed and can be found on the code list on the DSS website. In addition, it'll also be important for practices to bill claims with the specific qualifying place of service location. So that includes number 11 for office visits, 19 for outpatient, off-campus outpatient hospital, 22 for on-campus outpatient hospital. And then finally, the last criteria is to bill with the specific qualifying maternity bundle specialty type. That includes OB, including the subspecialty for MFM providers, certified nurse midwife, OB nurse practitioner, and women's health nurse practitioners. And then, like I mentioned, as a reminder, DSS is doing a softer kind of phase into the case rate. So for the first quarter of the program, from January 1st to March 31st, trigger events in the second trimester only will only be able to initiate case rate payment. So that means practices won't be able to receive case rate payment for patients who are in the third trimester or postpartum period. That'll continue in the usual fee-for-service way. And then effective April 1st in the second quarter, practices can fully trigger and receive case rate payments for patients who are in their second trimester, third trimester, and postpartum period. And as a reminder, DSS shared the final year one case rate payments that will be effective previously in November. So next, let's talk about some logistics in terms of what information providers will receive, how those payments are going to come through. So once case rates have been initiated, which will be identified through the submission of a trigger event, the trigger event criteria, which we reviewed on the previous slides, DSS is going to identify that case rate payments should be made and generate those at the end of each month. From there, expenditures will be included on the remittance advice as well as the 835 in the first payment cycle of the month. And so as a reminder, DSS is going to make all case rate payments to the Medicaid AVRS ID that received the most revenue in the prior year. This AVRS ID is included in that same final case rate letter that we shared in November. And so when you come and receive your remittance advice, you're going to see the client ID, client name, the from date of service, and the case rate payment. The from date of service is always going to be the first day of the month. And then in your 835, the case rate payment is going to be reported in the PLB section. It's going to include indicators so your practice knows that the payment is coming through as maternity bundle case rate payments. And all of this information is detailed in greater detail in the FAQ. So if you would like to see that more, I invite you to look there. In addition, in response to provider feedback, DSS is also providing a supplemental payment report. This is going to contain all the information that accountable providers will have the ability to attribute the TIN level payments to your respective providers and practices. And this report can be accessed by all providers under the accountable TIN through your secure provider portal. Just to kind of list out what this is going to include, that's going to include the client ID and their name, the practice TIN, the payment provider AVRS ID, that's going to be the ID that receives the payment, as well as the AVRS ID of the practice or provider who rendered care. It's also going to include information on the case rate, including month and year and case rate payment amount. And then finally, there's going to be an expenditure and recoupment indicator, as well as a transaction number. So next, we'll walk through just a quick example of what this is going to look like once the program goes live. So first up, in January, if a practice provides care to their patient who is in their second trimester, that's going to come through. Then in February, the practice submits their claim with the trigger event criteria with the January date of service. That January date of service claim is going to zero pay. And at the end of February, DSS is going to identify and recognize that case rate payments should be made for the month of January as well as for February. Subsequently, that means in the first payment cycle in March, the practices will then receive their case rate payments for those first 2 months of the year. And then if the provider is still the attributed provider in the following month, then they will continue to receive the case rate payment in the first payment cycle of April. In addition, just wanted to call out a couple of other things that DSS is planning to do once the program goes live. So like Brad mentioned, DSS isn't going anywhere after this program goes live, and the department is very much planning to continue close engagement with all Husky Health stakeholders. That's going to include more stakeholder and provider forum meetings such as this one. And the goal really is to be able to continue to listen to providers' experiences with this program once it launches, to listen for feedback and input, what's working well, where are there opportunities for improvement, and generally to make sure that we're able to answer your questions around this program. In addition, we recognize the importance of providing timely data. So data reports will be provided on a quarterly basis, which we'll preview in the next slide. There will be quarterly data reports provided around quality information or quality performance for your quality performance measures. And then at the end of the year, following reconciliation, DSS will also provide annual incentive payment reports so you can see how you performed over the performance year. Lastly, wanted to call out the support that is available through the CHN Provider Engagement Services team. So as you've been receiving several resources, such as your case rate letter through your PES rep, they will be your go-to person if you have any questions related to this program. They'll help triage and make sure they have you can get the support you need, including if you'd like to schedule any one-on-one meetings with DSS to answer any questions that you may have. Next, I will turn it over to Grace to give a quick preview of the quarterly data reports.
Hi, Tiffany. This is Sean. I'm going to do this for Grace. So I want to thank you for that. As Tiffany mentioned, we want to make sure that we're being transparent and we're working together as this program rolls out. So we will be putting together quarterly reports to each of the organizations that will have a dashboard for both performance measures, which you have some visual representations on this screen, as well as reporting measures, which we'll show you a moment on the next screen. The idea is that this would be provided in a rolling 12 months. That's really important for a couple of reasons. One, particularly in this first year, the data will become more meaningful with each quarter as we have more data to feed into the various measures. So you'll notice that in the materials you will receive on a quarterly basis, we do have a note of caution that some of these numbers will preliminarily potentially look like they're not meeting the threshold, which we expect as we start the program and data begins to flow into the model. So with that said, I think it's important to note that the official reconciliation calculation would not be happening until the end of that performance year, where we have the full set of data to demonstrate your overall performance. The performance measure information will begin to come to you right at the close of the first quarter. When we start talking about the reporting measures, there will be a slight lag with 3 of those measures, as they will be coming in through the encounter form. And we want to make sure that we give everyone enough time to start submitting those encounter forms, which is a slightly more manual process than pulling the data from the claims, which is where the other measures will be pulling information from. We can go ahead and go to the next slide. So as I mentioned, you'll receive a similar picture of your reporting measures, which it looks like here. One thing to note that will look different if you are an organization that have opted out of doula. The doula dials and data points would not be on your quarterly report, and you would not be expected to be submitting information on doula if your practice has chose to opt out. So that will look slightly different for you. The other thing that you will receive with your quarterly package, if you look on the left side of this screenshot example, you'll see it says measure descriptions, measure and weights, and methodology. We want to make sure that you always have the full picture of what is being defined with each measure. So you will receive a corresponding sheet with your visual representation of performance that describes each measure, how those measures were determined to be weighted, and the methodology of how the performance measures and all of the measures feed into your performance and improvement reconciliation calculations at the end of the year. All right, next slide. I think back to you, Tiffany.
Great, thanks, Sean. So as we close out the presentation portion of this provider forum, just wanted to call out some resources that are available. DSS really aimed to be responsive to provider questions and requests for more information. So you can see there's information relating to the program overall, technical details. Important ones to call out include the code list, program specifications if you'd like more on the technical details of the program. There's also additional information related to quality and reporting. And then for doula integration, DSS worked with primary maternity care and health equity solutions to compile a whole plethora of resources that doulas and practices can use for those who are partnering together and receiving the doula add-on payment. Like Brad mentioned, lots more resources. All of this can be found on the DSS website. And again, you're also welcome to reach out to your CHN provider engagement service representative if you have other questions. So with that, we will move on to any questions that this group has.
Tiffany, I don't know if the question in the chat, I know you already responded, if you want to verbalize it, if that's helpful.
Yeah, absolutely. So we received one question asking, how often will the supplemental payment report be supplied? If the report is monthly, what data will be included? So I will check if Sandy or if Deb is on the call to confirm that this will be a monthly report. If not, we will circle back and confirm, but I believe it should be monthly, and it will contain the client ID, last name, first name, middle initial, the practice ID, which is the TIN, the provider payment, the payment provider AVRS ID. This is the ID that receives the case rate payment, the accountable provider AVS ID, the case rate month and year, the case rate payment amount, the expenditure recoupment indicator, as well as a transaction number.
Thanks, Tiffany, so much.
Yep.
I don't
And
think,
then one other question and follow-up came in, will it be for payments from the previous months? Yes, I believe so.
I think Kat is on. Kat, anything you want to add? And we can bring that back and update an FAQ if we need to.
Nothing to add. I think Tiffany did a great job.
Thanks, Kat.
Great, thank you. We have another question in the Q&A box. So these payments, so the question is, are these payments aimed at providers? How are hospitals affected? Hospitals are not affected at all. This is strictly to providers. Where do we find the definitions and for numerator denominators for the quality metrics? That can be found in the quality measures reference guide, and that has all the numerators and denominators. And I believe we might be posting additional information with the program specifications coming soon. So you'll be able to even see additional information. We can send that out once it's posted to the DSS website. Where will we find benchmarks for each measure?
Great question. We will be providing, well, let me see if Grace or Sean wants to add in, given there will be dashboards with some of the quality measures on it. We will be having ongoing discussions about how we'll be posting some of this data in terms of the best way of communicating what the quality measure scores mean and where folks fall in that. But let me pause and see if others want to chime in and add a little bit more detail to that.
Like you said, we're still figuring out the best way to represent that, and we could likely do that a couple of different ways. I know in other programs in Connecticut, we've built it into the dashboard, and then added some definition in the specification description section. So we can take that back, and also talk with CHN to see if in addition to incorporating it into the dashboard, seeing if it makes sense to add something, at least describing it in the reference guide as well. Grace, is there anything you would add to that?
Nope, you covered it all. Thanks, Sean.
Yeah, and I'll just say, I think similar to as we get our quality reporting, both the dashboards out and also the end of year kind of reports, we'll be looking to kind of get feedback along the way to make them the most useful and actionable. We just know that we'll likely start somewhere. We'll hear from all of you what's the most helpful, and it'll probably be easier for you to have easier to give us feedback once we've launched this and you have some idea of how the process works and what this looks like. So we realize that we'll be launching something and we'll likely need to continue to improve it to make it more actionable for you and more relevant.
Yeah, and for performance year one, you'll receive those quarterly reports in a PDF type package. The goal would be in the future performance years to have it set up to where you have more direct access to your individual dashboard. But I think working through what that data looks like throughout the year with you will help us be able to move in that direction.
Thanks, Sean. For our next question, has your team run how practices would do prior to going live? I would hate for practices to run into a few surprises. Yes, DSS and Mercer did a historical simulation to do exactly that, see how practices would do prior to go live. Practices received a dry run performance report indicating, so they are also aware of their prior year performance. So that has been done. Grace, anything else to add?
No, we did, like Tiffany was saying, we did share that information a while back, I think as part of, reporting to the, indicate how the calculation works as well. I do also want to note, because in the past, obviously those quality measures that had like baseline encounter form in the future, we don't have that data available. So those were used, we use some placeholder for that. But other than that, the pay for performance measures we use the most accurate data we could have collected at that point to do the demonstration. So you can go back and look at those information. If you have any other questions, we can definitely answer them as well.
Thanks, Grace. Will we be measured against other participants, or will there be static benchmarks to hit?
It's always a percentile. I don't know, Tiffany, if you have some of the information shared here. Yes, but you can see how those tier score calculation, how those percentile are used to define your performance tier, and then you will get a corresponding percentage of share savings. And then you will get the performance tier score and then improvement tier score, and the max of the two score will be the percentage you will get of your share saving potentials.
Thank you. Next, hospitals are affected if they employ OBs or MFFs. Will the portal for data submission include a list of patients missing data, or do we need to track?
Start with the first one. Tiffany, just to say, Kim, thanks for that. Definitely appreciate that, especially for health systems that employ hospitals and have providers. There is impact. I think what we meant from before and what Tiffany was saying is that payments to hospitals do not change underneath this. So payments to hospitals are not initially, but professional fees can be. So for example, if you're a practice that sits underneath a health system and you are a maternity bundle provider and you bill for delivery for a patient that you're getting a case rate for, that is zero paid. So the provider fees are affected. Those hospital payments for care are not changed or not affected. Tiffany, anything else to add to that nuance?
No, I think you covered it.
And thanks, Kim. Very, very appreciate that many of the larger providers and health systems do have maternal health groups, and so we definitely appreciate that and know there's some nuance here. So thank you for pointing that out. Oh, the second part of your question about the data submission, including a list of patients missing data, or do we need to track that? And are you talking about missing data in terms of could you add a little bit of color commentary to that? I just want to make sure I'm understanding that.
Yeah, so and thank you so much for taking my question. When we currently submit through the P4P, we have to track the patients that we have submitted and have not submitted. I was just curious if in this new portal, there would be sort of like a task list where here's all the folks that are attributed to you that we are looking for data on. And, we would have sort of a gap there that we could easily visually identify.
Well, it's a good question. I think we might take that back,
Okay.
Kim, but we appreciate the question. And just to say, there's been a lot of really great questions that have come up in these forums and others that have helped us kind of refine what we're doing. And so this is an example of something where we will be able to take it back and kind of look at what we're planning and putting out there.
Thank you so much.
Thank you.
Cindy, I see your hand. Is this a follow-up question or a new question?
No, just a comment on Kimberly's comment. What I noticed the difference between this program and the P4P is we really don't need to submit the encounter form until after the delivery and the postpartums. So whereas P4P had a time frame around getting in those prenatal visits, this program doesn't have that same stringent timing around it. So, our thought is we just wait until the, 90 days after, the delivery. And at that point, because you have like 120 days to get the encounter form in. So like around day 100, you work on the encounter forms.
Thanks, Cindy. That was a helpful clarification. Next question, OB providers have no ability to reduce the rate of low birth weight, SGA newborns. Rather, providers have the ability to diagnose and apply the indicated pregnancy surveillance when fetal growth restriction is identified.
Yeah, I appreciate that. I might gently push back and say we did try to review this as part of our quality measure evaluation process, and did find that there's a fair amount of interventions that can reduce low birth weight for some individuals, not necessarily across the board. Obviously, there's certain things that can't be modified, but there does appear to be a number of various interventions that providers can do that can impact birth weight for some members. And so we did include that as one of our pay-for-performance measures.
How should this be initiated? Could we get a little bit more clarification on what this is being referring to? Okay, we can come back to this one. Next, how can we ensure providers are not discouraged by this metric? Is that one referring to the low birth weight measure, I'm assuming?
Yeah, I can imagine that might be. I think what we're trying to do is to say, and you'll see in terms of the balance between shared savings and quality is to say, we know some of these making movements in some of these areas is challenging in terms of some of these quality measures, but we do think they are really important quality measures for improving the health and well-being of our members, especially those who have been marginalized the most. And so what we're trying to do is to provide actionable information to providers on a more real-time basis, including what Sean was talking about with those quarterly reports, so that there can be open communication about where providers are performing well and where there's opportunities for improvement. We do see this as a partnership in the long run, because in the end, we want providers to participate and enjoy participating in this program and see value in it. And we want to see members have improved outcomes. And for us, that means we need to engage with all of you to get feedback and try and improve this program along the way. Understanding there's going to be challenges, and obviously we're not going to see eye to eye in every single thing. And so we've really tried to balance that as best we can, understanding, we definitely have heard from some providers about disagreeing with one specific measure or another. And so those will be things we want to have ongoing conversations on over the years as we move this program forward and try to improve it. Is what's working well, what's not working. We may need to change quality measures over time as these changes. Right now we have C-sections as a quality measure. There's definitely a floor at which we don't want to see sections go below, because that actually may lead to harm. And so just to say, these are things that need to have, and this has come up from many of you in the provider community, that this is a ongoing program that to be successful requires us to engage with all of you. But I just want to say we understand some of the concerns that you're raising, and we definitely want to continue to hear them and work with you in the larger group on this.
I'll read our next question. I know many smaller practices in the community. Do we have good outreach for them? I don't want to see them surprised. Yes, DSS has done outreach with each practice that's going to be participating in this program. So that includes sending program resources such as the case rate letters, their historic performance reports. So DSS has really been trying to engage with all providers to ensure there are no surprises there.
Yeah, and a big shout out to the CHN CT team, so Kim Osno and their larger team and Rich Spencer. Kim, I don't know if there's anything you want to add in terms of further details about that outreach that you and your team have done, which I think has been a really aspirational part of what we've been able to do in the last year of this program.
Yes, Dr. Richards, we have great contacts at each of the practices that have been identified as participating in the bundle coming January. And any sort of communication, we make sure we outreach with an email or a call, or even in person if needed. So any sort of a resource that has come out, we make sure that all the practices that are in the bundle have whatever they need.
Cindy, did you want to add anything?
Now, I just have a question with this slide right here, because it says five are pay for performance measures and 5 are pay for reporting measures. But it's my understanding only 3 of these are what are going to be addressed via the encounter form. So I guess that's confusing, like the 5 are pay for performance. To me, I feel pay for performance are what you're getting off the claims, but maybe I'm thinking of this wrong. Like how you do the 5 and 5, like how do you decide pay performance versus pay for reporting? I thought the encounter form was the pay for reporting.
Yeah, that's a great point. So the pay for reporting, you can just think of in terms of these are measures that DSS wants to collect additional information and data on. So number 6 and 7 for contraception, preterm birth and labor, these measures are actually claims-based. So that's why when you fill out the encounter form, you only have to fill them out for dual utilization, breastfeeding, and behavioral risk assessment.
Thank you.
Next question, will there be a way to bulk submit to the portal or just per patient? If Mark or anyone from the CHN team wants to weigh in here, but generally just to start, DSS and CHN did explore if there's a way to bulk submit. There are some challenges, such as not being able to confirm complete data submission for practices that make this a little bit more challenging. And so the recommendation currently is to do a per patient submission. Next question. Some of our clinics have mixed practices covering, would the patient be attributed to the practice who saw the patient the most?
I can take it.
Oh, go ahead, Grace.
Yeah. Sorry, thanks, Tiffany. I can cover this question. So it's all by like how you bill and the timing of it for each month. So it will I just want to say if, a patient has been, for whatever reason, has been seeing or has been receiving services from multiple practices, then we just use the date of service for each month to decide the final attribution for that month. So for instance, if a patient see 2 accountable provider, 2 participating practices, A and B, in the month of December, let's just say. And then the first service from provider or practice A incurred in early month, and then the second service from practice B happened late month. And then for that particular month, both practices will be receiving their individual case rate. But since the practice B did the service at the end of the month, this episode will be attributed to practice B in the following month, unless someone else claimed it in the following month. Otherwise, practice B, as the second in chain service practice, will get the case rate going forward. Hopefully that helped. So it doesn't matter, who see it the most. It's just the timing, and for each month, which practice this episode is attributed to.
Thanks, Grace. Will there be an ability to submit files electronically or manual entry? So we covered that one. That's something DSS and CHN are working on. As of right now, recommendation is to do manual entry. How do these metrics not unfairly impact MFMs who take care of the highest risk patients who are most apt to experience adverse events? What would stop general OBs from just offloading their patients who would affect their metrics?
Yeah, definitely. I know this has come up a few times. And so just wanted to note a few things. So one is one of the measures which has been discussed quite extensively is the maternal adverse events measure, which was a measure actually developed by Yale Core, mostly focused on inpatient and hospital level measures, which we are applying in the outpatient setting with Yale Core's assistance to apply it in this fashion. It is a risk-adjusted measure, which I think is important to note. And I think the other thing is that our C-section rate is looking at those who are born for more than 37 weeks in their first pregnancy at C, which obviously can sometimes be C-section, but we see that that higher risk pregnancies maybe fall outside of this specific measure. And then prenatal care, I think timeliness obviously is going to be important across the board. And then postpartum care, again, I don't think there's something that MFM providers should be held accountable for. Definitely understand the low birth weight concern, depending on what the fetal growth restrictions could be. Again, these are things that we're going to be looking at over time. I will note there's two pieces to this. So there's a peer, the peer component of the accountability, and then there's an improvement piece. And so there are two ways of scoring in this. So it's not just how do you do comparatively? It's like, do you improve over time compared to your prior score? So just to know, there are two pathways to improvement over time here. And these are things that we will be continuing to monitor and look at. Cindy.
I'm sorry, I feel like I'm beating a dead horse, but the supplemental files, like we currently send supplemental files now to CHN. So it's kind of like to try to understand why we wouldn't just be able to add, these 3 discrete fields to that supplemental file to, meet the needs versus, to have to manually input all these encounter forms and find resources to do that input.
Yeah, definitely hear that, Cindy. We're gonna revisit that internally again. It'll be something we've heard that, hear you. We'll discuss and see what's viable.
Great. Sorry to beat that horse.
We understand it's often these pieces, the administrative pieces, which can be challenging, and so we do want to make it as easy as possible within what is feasible and what could work. The other thing I didn't answer on the prior question was about what would stop OBs from just offloading all their patients who would affect their metrics. I think one is, so I'll just note we do have a plan to monitor over time for access and what providers are seeing which patients. We will be kind of looking at this on an ongoing basis to monitor for access. And just to note, we do have kind of a standard size. It's about 15,000 births every single year that are seen. It would probably be challenging for providers to offload specific patients and to do that, though admittedly that is something we are going to be looking at in terms of is there people trying to not see higher risk members. Again, I will note one thing, that our shared savings program does risk adjust. There is clinical and we're doing some social risk adjustment. So just because someone's higher risk doesn't mean it actually may create opportunities to provide better care and reduce the cost of care and then actually capture more savings. So there's actually potential upside, and that's how we've tried to craft this to have make sure that we're doing social and clinical risk adjustment as part of that, so that providers have an incentive actually to try to take care of higher risk members as part of this program.
Thanks, Brad. I'll move us to our next question. Is there reimbursement for first trimester services in late 2024?
we're still paying, we haven't changed the payment model until 2025. So everything is still kind of as it is until this program launches on January 1st. So through late 2024, all of those dates, anything that date of service in this calendar year will be as it is and has not changed.
Next, a follow-up question for the low birth weight measure. In the bundle resources, can you provide the interventions OBs can provide to reduce low birth weight in a current pregnancy? Aside from broader public health measures, I am not aware of how a provider can do things to directly affect the growth of a single fetus.
Understood. Yeah, we have to go. It's honestly been I think Tiffany, we reviewed this a couple of years ago at this point. So we need to go back and figure out what we had pulled at the time. If I'm not mistaken, one of those, not surprisingly, they're probably the one that is very clear in my mind, the smoking cessation, which is there is a very confident, fairly good data on. Obviously, that's a very particular one, only for specific populations that has tobacco use disorder. But there were other ones that I recall us discussing at that time. So we can try to pull a few things together and post it onto our website.
Thanks, Brad. Next question, if a practice sends a patient to an outside MFM, are the MFM fees outside the bundle? Grace, could I pass this one to you?
Yes, Tiffany. So great question. That I will say the fee for service. So if it's an outside MFM and the MFM is not associated with another participating practice, if it's not, if the MFM has its own practice or for whatever reason that practice or their associated practice is not participating in the program, their services will be reimbursed fee for service per business usual as of now. But if this outside MFM is associated with another practice that is participating in a bundle, this will be an opportunity for the other practice to claim the case rate from that point onward, unless the patient comes back to your practice and you re-trigger that case in the following month. So MFM, basically what I'm trying to say is MFM is not treated any different than any other providers associated with a practice that participating in the program.
Thanks, Grace. Next, we have a comment. By definition, MFMs will have higher rates of NTSV cesarean delivery, higher rates of preterm birth, higher rates of maternal adverse events, and would not have the same metrics of low risk births.
Yeah, and I think we touched on this one. I think we definitely hear the concern, and it's something we'll be looking at. I will note again on the maternal adverse events, there is risk adjustment. This is the measure that is a risk adjusted measure. We are very interested in being able to do clinical risk adjustment on measures when feasible, but this was the only one that was available that we could implement at this time. It is something, again, we'll be looking at, and I will just note that there is a self-improvement component to this that providers will have opportunity to perform on as well. But this is a piece, and we have definitely heard the concerns about including MFM providers in this. Ultimately, we, especially as we think about the highest risk members, that we see benefit to having this type of payment model in place for those highest risk members as well, to increase that accountability that providers have, and also flexibility of care, especially for those higher risk members that might have significant potential substance use disorders or ongoing behavioral health disorders that may not be as well treated prior to pregnancy. And so we definitely hear the concerns. It is something we will continue to revisit because of the concerns that have already been raised. And we'll be looking to think about, do we need to make any tweaks specifically on this topic as we evolve the program over time?
Next question, will practices sitting in hospitals, hospital-based clinics be disadvantaged? The costs are certainly higher to see patients in a hospital.
I can take this question too. So first of all, case rate is only meant to cover all professional services. So anything, from an inpatient setting, or anything that's like a hospital service cost is not going to be included in the case rate and still will be reimbursed fee for service. But if we're only talking about professional portion of those services, they are covered by case rate. And because our case rate is set based on historical cost, if historically those costs have been higher than the other practices, those are already reflected in the case rate.
Thanks, Grace. Will we be stimulating bottles between practices if only one practice is getting reimbursed each month? Do I have this correct? So just to clarify, the case rate is set up in a way where two practices can receive case rate in 1 month. This is certainly not to create any battles between practices. The goal of the case rate is for practices to kind of raise their hand and take accountability for when they're caring for a patient. And if there is co-management for between practices, then both practices, if they're submitting trigger event claims, will be receiving the case rate. Anything else to add there, Grace?
Nope, Tiffany, you covered it.
Perfect. Since there are several contraception methods that you would not see on a claim, how will that affect the scoring of the measure?
Yeah, I think happy to jump on this one. So this, the contraception measure is a pay for reporting measure only. We never intend to add it to a pay for performance to avoid any coercion around contraceptive use by members. We're really looking to collect better data than we currently have, as noted in the question, that there's sometimes challenges in identifying contraceptive use that's going on. And so really looking to use this to better identify use of contraceptive in the postpartum period so that we have a better sense of it at the state level. So again, it's a pay for reporting only. There's there would not be a plan on this specific measure to ever move it to a pay for performance one.
Our next question, following up to the co-management, will the case rate be prorated between two co-managing practices? No, the case rate is set for the entire year 1, and so you will receive your full case rate if you're co-managing a patient.
Correct. Thanks, Tiffany. And just to say, we definitely intentionally put it in this way so that there's not a disadvantage for co-management. We want providers to be made whole or better as part of this program, as part of how we've tried to structure this, based off of how the case rate is set and allowing multiple providers to receive a case rate in a single month.
What about prenatal ultrasound done by MFM, but prenatal care delivered and delivery carried out by a general OB clinic? Prenatal ultrasound professional charges for fee-for-service or bundled into the case rate payment?
Grace, do you want to try that one first?
Yeah, so I will, again, I think that's a very billing specific question. I will recommend going to the case rate code list published on the DSS website. So assuming, I don't think the prenatal ultrasound service is, correct me if I'm wrong, Tiffany or Dr. Richards, like, I don't believe they are covered by case rate, but if they do, let's say they are covered by case rate, the code is including the case rate code list, and it's done by an MFM that is not the general OB clinic, is not associated with it, then that event will allow that MFM, again, if it's associated with another participating practice, to trigger the case rate start. But if, again, the member comes back to their general OB clinic and then for their any other type of visits, and then the general OB clinic trigger the case rate, the case will return back to the general OB office. But if the prenatal ultrasound is not billed by one of the code covered by case rate, then that will just be reimbursed fee for service.
Go ahead, Tiffany.
Oh, yeah, I was just going to say, yeah, I think you can see the case rate code list, which is on the DSS website, to confirm specific codes that are included in the case rate. I think we've answered most questions. We have 3 minutes left, so feel free to sneak in some questions. And again, you can contact your CHN provider engagement service representative if you have additional questions or would like to schedule a one-on-one provider meeting with DSS.
And I'll just take the opportunity to say we very much appreciate the questions that we've heard today, as well as the ones we've heard prior to this. It just helps there's a lot of great questions that sometimes we haven't thought of, and it's helped us improve the structure of our program over the last several years. And obviously, again, we won't always make the changes that are recommended, or we don't always see eye to eye, but we will definitely try to consider everything and take a look at it seriously to identify, like, is this something we can do now? Is this something we should consider for a future iteration? And we will be closely monitoring kind of the rollout of this program and the impact on providers.
Two more quick questions came in. Any systems for smaller practices that buckle under this pressure?
I guess when you talk about systems, any particular systems you are that you're asking about? Just to say, in terms of failing on metrics, this is just a little bit of again, just to mention the program structure. It's the case rate is that gets triggered in the second trimester. So again, first trimester you get paid fee for service traditionally. Second trimester you can initiate a case rate that requires the E&M code and a trigger diagnosis to be billed. That initiates the case rate, and that can continue on for 90 days postpartum. The quality measures tied to shared savings. That's a upside only shared savings program. And so those metrics have an impact on the shared savings, but not on the case rate. And the case rate's built off of historical billing patterns to make providers whole based on their prior historical experience. We understand there is administrative burden that goes with implementing this. And so we just want to recognize that this isn't just a turn on and take some effort. And so just acknowledging that there is a few extra dollars that are going into this, partially as lactation support and partially as doula support. The only one I just wanted to quickly comment, I saw that, and if there is any concern about from the practice, we at DSS and CHM would welcome hearing about concerns that smaller providers or others are having with this. And I will wrap in just a second here, just to say, I saw the question about, it doesn't make sense that practices assume any other parts of the prenatal care beyond ultrasound to be using the case rate. So if a provider just is doing an ultrasound and is billing for that, and if there's not a E&M code and not a trigger code billed, that will not initiate a case rate, and that will still be paid fee for service. So in order to initiate the case rate, an E&M code plus a trigger code have to be billed. So if it's a ultrasound that is billed only with interpretation, that's not an E&M code, that can still be billed fee for service. So if that's the only service that's being delivered. Anything, Grace or Tiffany, you want to add to that?
That is totally correct, Dr. Richards. And also it has to be the right setting, right? So I think in one of the slide today, Tiffany outlined the 4 criteria that is needed to trigger an event. So, if there's no E&M code or trigger code, or it doesn't have the right setting, and then the ultrasound technician or whoever the billing specialty is not one of the maternal care specialty, that will not trigger the case rate.
All right, with that, we'll wrap up. Thank you all again for being here. We understand a lot of again, we appreciate the questions, the concerns. We are here to continue to kind of work through this, and we anticipate spending more time with you all after launch. So thank you so much. Hope you have a great December, and we'll be in touch.
Thank you.